This is Amy Gibson with the Patient-Centered Primary Care Collaborative. I want to thank all of you who are typically part of our weekly Thursday call. For all of you who have joined the call today and are part of this webinar, you're brilliant. You got everything right as you should have. So you followed all the instructions we sent out, even knowing they were very last minute. So I really appreciate all of you working with us as we're kind of moving to a new way of doing some of our calls in this upcoming year. So again, Happy New Year to all of you who've been a part of our Thursday calls in the past, and for those of you who are joining us for the first time, we certainly want to give you a great big welcome. What we're trying to do in this new year is to get more of you participating in a lot of the information sharing and networking opportunities that we have here at the PCPCC. But we also want to make sure that we're providing this information in a way that people who don't have the opportunity to maybe jump on the phone calls with us at 11 Eastern Time every Thursday, then this will give us the ability to put together information that will be accessible up on our website long after these calls happen. So again, thanks to all of you for bearing with us as we start to make this transition. You will continue to get a weekly newsletter. So every week we're going to send out that medical home newsletter, really showcasing everything that's going on around the country, the real pertinent issues. We're going to continue to share all of your announcements, so don't hesitate to continue to send those to us. We want to have those included in our newsletter. We'll certainly be sharing announcements with you about what's going on here at the PCPCC as well. And if you have questions or other concerns about our new schedule, because what we're going to be doing is moving our weekly calls to monthly calls. So the plan is we're going to be having a call like this at the last Thursday of every month, so the last Thursday. So our next typical Thursday call will be on January 31st. And because we are trying to invite more speakers and experts sharing their knowledge and information with you in a little bit of a more informal way than what we would do on a typical webinar, we might be sending out some of those links again so that you will have to log in ahead of time to jump on the call. But of course, you can always follow those links and join us while it's actually happening live too. So don't feel bad if you didn't get on the call right at the time of the start. You can always join a little bit later. And again, we'll have all of these archived up on our website so you can always go back and see what you missed. So again, thanks everybody. I am, because this is a little bit of a different format, going to give a few announcements just to remind everyone again that you'll really have to pay attention to the email communications that we send out and really look through those, because I won't have the opportunity on future calls to go over a lot of that information, and we won't necessarily have a chance to have a lot of discussion about it because of our agenda is going to be a little more structured. So be sure to pay attention and look through the information that we're sharing with you every month and those communications that come out by email. For those of you who had the email shared with them by a colleague, you can certainly go to our website and sign up for information. And then if you're also not already signed up for communications for our various centers, I would encourage you to do that. Today's presentation is sponsored by our Center for Patients, Families, and Consumers. And I do want to make mention, too, that even though all of our centers have actually been coming together this week and will continue to come together next week for some retreats by the leadership, we're really going to be making a very strong concerted effort in this year to make sure that patients and families are really involved in every aspect of what we do. You know, in the past, the PCPCC was really around advocacy, trying to spread this idea, the concept of patient-centered medical home, and why we think we really need to improve primary care if we're going to transform our overall healthcare system. But now we're really moving into the next iteration of our organization and of the medical home. Now it's all about making it happen, making it a reality. So we know we absolutely have to have patients and families a part of that process as well, and caregivers and other people who've tested the system. They know what works, they know what doesn't work. So we want you all involved in quality improvement at the practice level. We want you participating here at some policy and advocacy level related stuff that we do here at the PCPCC, and I think we do pretty well, but we want to share your stories too. So I would encourage you to get involved in any of our centers, and again, please go to our website And you can click on any of the 5 centers that we have to find out more about what they're doing and how to get involved. But especially for those of you who have experience working with patients and families and caregivers as advisors in your practice and as part of healthcare transformation, I really strongly encourage you and the patients themselves to participate and to reach out specifically to me or anyone here on the staff of the PCPCC. We really want to share all of your expertise in this as well. So I'm going to move on to a few other announcements, mentioning those centers again. In February, we're going to have open calls for all of the centers. We've got the calendar up on our website, so you can find out when all of those are happening. Again, you'll get to hear on those February center calls about all the work that they're doing at these retreats this week and next, and then you'll also have an opportunity to share some of your resources and experience and provide some feedback to the leadership. So we'll have some technology that we're planning to employ to help do that in a way that's really easy for everyone to participate. So if you could go ahead and get those on your calendars, we would really like you to participate in those calls. We are going to continue our same format with our regular webinars, our formal presentations. So we have a webinar coming up that's in our newsletter. There's information about that, and it's going to be on shared accountability in the medical neighborhood. And this webinar especially, I think, is going to be something a lot of you will want to participate in and many of your colleagues, because we're going to have several different points of view. We're going to be hearing from an employer who's talking about what they're thinking about in benefit redesign and why they think that this is an important aspect of the benefits in the healthcare system that they're trying to get access for their employees. We're going to hear from a large health system talking about the people that are actually working as part of that between the specialty services and primary care. And then we're going to hear from a primary care physician who's going to be talking about how in her practice they've really worked to collaborate better and have some of that shared accountability with specialty services. So again, that information is in your newsletter, and it's going to happen on January 30th. Registration is open for that. I want to make mention of another announcement that's in the newsletter today. This one is especially timely. RAND Corporation is sponsoring a focus group. They're really looking for primary care clinicians. They want to ask some questions and get some information about how primary care clinicians are collaborating with emergency rooms in their community. So the deadline for that is January 15th. So we encourage you, if you're working in primary care now, to go and sign up for that. All the information is also up on our website. So again, the deadline for that is pretty quick turnaround. So it'll be on a first-come, first-served basis too, because I'm not exactly sure how many individuals they're looking for, but the focus groups are a little restricted in terms of how many people can participate. So I wanted to draw your attention to that. We also have materials up about some upcoming conferences for PCPCC. As many of you know, in March we are co-sponsoring the Medical Home Summit that will take place in Philadelphia. We're partnering with the Jefferson School of Population Health on that conference, so if you haven't already signed up for that, I would encourage you to do so. And then for our big PCPCC conference that we're having back here in Washington, D.C., in the fall, we've got a lot of information up on our website now about sponsorship opportunities for that conference. We've got a great venue. We're going to have an awesome exhibit hall, lots of different ways that you can get your organization's name out there, show your support for Medical Home and the PCPCC. So if you have any questions at all about sponsorship for the conference, please send an email to Anna. Her email address is ana@pcpcc.net. And I think that's all the announcements that I have. Okay, so this is how we're going to run this particular webinar today, webinar/call. On our usual webinars, we only give you the capacity to ask questions and type them in the question box. You can still do that, but you get a choice on today's call. You can either type your question in the question box that you'll see on your dashboard, or if you click on the audio button under the audio screen, if you choose telephone, and hopefully for those of you who have questions, you'll use your telephone and call in. The audio quality is usually much better. So use the telephone, call in with your question, and there's a function you'll see, raise your hand. And we'll try to get through as many questions as we can. So you can, again, ask questions by clicking the raise your hand icon, We'll get you in the queue to ask your question, or you can type it into the question box. If you do have specific questions about kind of our new format, things that are going on with the newsletter or call or announcements you want to share, please do type those in. We'll reserve the live audio questions for Brad so we can have kind of a discussion about our topic today. So I've talked too much. I'm going to move this right on over to Brad. And again, I want to thank our co-chairs for the Center for Patients, Families, and Consumers, Francis Rienzo and Christine Bechtold. Unfortunately, neither of them could be with us today, but again, I encourage you to join the center and learn from not only their vast experience in working with patients and families and consumers, but to also join many of the other incredible leadership that we have as part of that center. And I thought that it was really important, again, as we're making this a very strong focus of our activities in this upcoming year, to get patients and families engaged in practice transformation and medical home implementation, that we really start off the year talking about this, because it is so absolutely critical to our mission. So I'm not going to give you a long introduction, Brad, because, again, I've already talked too much. But Brad is an incredible colleague, and I'd like to say friend of mine. We've worked together in the past. He has just an incredible wealth of experience that I want him to share with you today, but he also has a great vision for how we can really get patients and caregivers more involved in primary care and improving the healthcare system. So, Brad, I'm going to turn it over to you and let you tell everyone about yourself and your experiences.
Thank you, Amy. I think I've taken control of the machine here. I want to start by just saying that I'm really honored to get to speak with all of you today, because honestly, when Haley showed up in our lives 23 years ago, we had no idea the impact she was going to have on our lives, the impact she was going to have on other folks' lives, and really including a total career path change for me. So it's been an exciting journey, an interesting journey, and not always a pleasant one, but we have been just incredibly blessed to be able to speak with people, talk to people, and I don't have control of the PowerPoint. So
you just click into the box there. You should control.
Okay. It just says can take control.
Wiggle your mouse around on the screen and click your screen.
There you go.
Okay, thank you. I am incredibly technologically challenged, so if you've ever met me before, you already know that. So there we go. Let's go back. This is our motivation for this work. I show Haley the pictures that I'm going to show of her and tell her the stories I'm going to tell about her before, so just want you to know that we're not exploiting anyone here. The reason we use this, we have some more formal pictures, but this really gives a little bit of a glimpse of the personality of Haley Thompson. And while we would have never chosen the journey that we're on 23 years ago, I can tell you that I'm really thankful that we didn't have a choice in that matter, because if I had, I'm not sure I would have had the courage to accept that challenge. And I'm fortunate that I didn't, because life with Haley has taught me most of the most truly important lessons in life. I watch her and I see a person who is so quick and easy to forgive. She will say it's okay before you can get I'm sorry out of your mouth. I watch her love people so easily that if you ever meet Haley, if you don't get a hug from her, it will only be because you don't allow her to. She's just an amazing young lady in the way that she handles some significant both physical and cognitive challenges. And because of that, she's probably, no probably to it, our greatest inspiration. I'd also say that life with her has led us to a work that has allowed us to meet and work with some of the most amazing people in our country. And I've just been, I feel incredibly blessed and in awe to have been able to work with people like Amy Gibson for a number of years and to learn from them And so I just see this that we're doing today as the next step in a journey to really serve families and hopefully serve them well. I want us to think in terms of using patients and family members as team members. This work is incredibly important to me, but maybe for reasons that wouldn't be so clear to you. Karen, my wife, and I owe an incredible debt of gratitude to Dr. Sherry Medford, who has provided our medical home for Haley for about the last 15 years. And so many other families owe Dr. Medford such a huge debt of gratitude. And it was interesting the way that I met Dr. Medford, because she herself has a child with Down syndrome. And we were doing a training in the Amarillo, Texas area. If any of you don't know where Amarillo is, look at the map. We're in the middle of nowhere at the top of Texas. She came to a training to help her to understand how to navigate school systems and social systems and those kinds of things to help her daughter Erin. And when the training was finished, she came and she asked me if I would be interested in talking to her families as she meets them through her private practice. And I said, sure. I said, I would love to. And so she began to give my phone number out to families who had children with special health needs and would call me semi-regularly, very frustrated because no one had ever called. And I kind of understood that as a parent, that my list of to-dos is plenty long. And so to add the number of a stranger that somebody tells you ought to call or it might be helpful to you is something that's probably never going to make it to the top of the to-do list. And so we started thinking out loud, how can we connect to these families? And I introduced the idea of just showing up to her office one day a week. And so what we started doing about 6-7 years ago now is her front office staff scheduling well child visits for kids with special needs on Fridays. And I will go to her office on Fridays and just sort of hang out. And when she's through or while they're getting shots filled or things like that, she just asks if they would like to speak to me. And if it's a first time, if I've never met them before, she gives me a brief introduction. But over the 6 or 7 years that we've been doing this, we've only had one parent who ever said, no, I don't want to talk to him. And there was a bunch of situations involved in that. But what it did for Sherry was take some of the load off, some of the conversations that she felt kind of, stuck is a strong word, but that there was nowhere else for these folks to go. And so as they start asking questions and bringing up ideas or thoughts, that it really cost her a lot of time. So we were able for her to be able to say, I would love to talk to you about this, but I have a parent here who has been down this road a little ways and has navigated this system before and has worked with school and worked with social systems and all of those things, and he can probably give you more hands-on direct information than I can. And it allowed her to leave the room and her families still be served in a very, maybe even more comprehensive way. And so I've enjoyed doing that work. But what I want you to know is that in many ways it's our attempt to repay people like Dr. Medford for all the things that they do for us. That if we can make life just a little bit easier for her and those of you who are on the phone, then we feel like we have repaid a debt that we kind of owe. That's what we want to do. And we want to take the burden off that we can. We also want to try to make sure that primary care physicians that are doing their best to create good and healthy medical homes stay in this work for a long time, because you are so desperately needed. In any line of work that I've ever been involved in or tried to help people with in systems analysis or anything like that, I've always heard somebody say something like this: if I could just afford to add one more person, I could fill in the blank. I could provide this much more service. I could get to this many more phone calls. I could, just fill in the blank, and it's everywhere we go. And so that's one of the things that I kind of want you to think about today is what are the holes in your team specifically, or maybe a team that you know of that you're engaged with in some form, especially in the medical community. I've seen the work we are doing, training parents to work in pediatric practices and hoping to grow into family primary care practices, really help to fill some of the most common holes that we hear about in primary care. We can support a lot of things in a practice that improve care, that improve efficiency, and improve family and provider satisfaction. How do we do that? Who knows better than a parent who's been down the road further than maybe the person they're talking to? Who's better than a parent to know not only what number to call for a certain resource, but also know the name of the person at that place that will get it done? I think you all know what I'm talking about there. It's one thing to call the Social Security office. It's another thing to know that if you call Sue at the Social Security office, she will not rest until she gets your question answered. Well, Sue's the one I want my busy parents to talk to. Who knows that better than a parent who's probably talked to the other 3 or 4 people in that office before they found Sue? Who can be the best encourager of another parent to follow the plan that the doctor's given them? To say, I have total faith in Dr. Medford, and if she's asking you to do this, it must be important. She knows that you're busy, so she wouldn't give you anything that she didn't think was important. When that comes from a doctor or a nurse, it can sound even a little self-serving, but when it comes from another parent, it adds an additional weight to that statement. Who can speak into the parent who struggles with their partner being in denial, especially husband, better than another dad? To just talk about how do we handle that? How do we deal with that? Who better to speak to someone who is invested at an unhealthy level, that is unbalanced, than another parent who can say, look, this is a long journey. It's way more of a marathon than it is a sprint, and so we need to pace ourselves and to take care of ourselves. And who better than another family member to speak into the guilt of a spouse who really needs a break in taking care of their terminally ill partner, but really thinks she should be strong enough to not need a break? Who better to do that than someone who's been down that road before? I hope you get the picture of that a healthy, trained family member can quite naturally take conversations that other professionals weren't trained for, not reimbursed for, and that really can create a lot of scheduling challenges. I want us to take a look at some of the items of the medical home that a family team member can really support. The first one is comprehensive care. I think a parent or family partner, whatever you want to call them, really bridges the gap between the medical practice and other major areas of concern for the family. It's one thing to really know about the medical piece, but when we start receiving diagnoses, especially for kids, it starts to put us in arenas that we were never considering would be a part of our lives. And so to have somebody who has experience with those other arenas is really valuable and incredibly time-saving for people in the practice. I've been told that when I put up the family-centered piece and I say, well, it seems fairly obvious, I've had people tell me that's not really obvious for a lot of folks. I think being family-centered and having a family member engaged in your practice gives an insight into the challenge of really balancing all of the different things that a person has to do, whether they're taking care of an aging parent, which we are currently doing with my wife, with my wife's father, or it's trying to raise a child like Haley while having other children in the home. All of those things come into play, and having another family member be able to talk about and encourage the idea of balance is really, really valuable. The third thing that I think family partners can help us with is coordinated care. I think a lot of times in the medical arena, and you can shoot me down if I'm wrong in your particular area, but a lot of times we consider coordinated care to be coordinating things within the medical arena. And that medical arena, while it is huge and it takes priority when our kids or our family members are ill or are struggling with an episode of a chronic illness, that there are a lot of other areas that have just as major an impact in our lives. And to be able to have someone that they can connect to and talk to outside of the office visit to talk about how to balance those things and maybe how to prioritize those things, really helpful to the quality of care that they receive, as well as being really helpful to the office, because that just takes one thing off the plate. The fourth item of the medical home elements is compassionate care. I believe it is irreplaceably important for the doctor to take some time to provide the compassionate care. I think it's important for a physician to have a relationship with his patients and with his families. But if the practice has someone who can actually walk the path with these families in an emotionally healthy way, the doctor can operate more efficiently. Dr. Medford actually gets a bump in the way people see her practice, because she can hand them off to me and I can take them down the path right there when she may or may not be able to, and would have to get back to them or have a nurse or a front office person get back to them. And because of that, we can just provide that. And the Amarillo Children's Clinic gets the praise for that, being more compassionate and more coordinated. And then finally, I believe we're able to produce a more culturally effective medical home, not because we have a person of every ethnic origin or every language spoken in our community available to them, but we do have people who live in that community who know how the communities work and probably have a connection even into that ethnic group in our community. And so we are able to be maybe even more culturally effective. And I want to spend the next few minutes talking about the benefits to different groups. And I'm not changing slides here. There we go. The benefit to families, and most of the time we say, you know, these are obvious. Everywhere I go, I hear providers talking about the importance of this, and I'm thankful that that you guys are emphasizing this over the coming year as you kind of look at the direction you're going. But it's more than just that. I think one of the benefits to families is that it gives them someone who's been there. And if we can provide them with someone who's been there, who is still healthy, relatively healthy and relatively sane, it allows them to see that maybe I can do this. The second thing that it gives them is someone that they can talk to away from the doctor's office. You know, it's really difficult to pick up the phone and just get Dr. Medford on the line. It's not that difficult to pick up the phone and get me, or at least leave a message and allow me to get back to you fairly quickly. It's not difficult at all to do that. It gives them not only the where, as I mentioned earlier, but the who. And that is so incredibly important when we don't have enough time to get through the to-do list anyway. I think the next three slides are some unique blessings that a family member can give to another family member that are incredibly important supports to both their mental health and to their ability to maintain their participation in their family member's journey. The first one is support through the grief process. These are journeys that no one wants to take, but the burden is lessened by knowing you're not alone. Until you've experienced this in some way, you probably don't give it much thought. I know that we didn't. Until Haley was born with multiple physical and cognitive challenges, we didn't understand. We didn't have a way of measuring just how intense and how complicated it can be. Until my brother was diagnosed with cancer at age 41 and passed away at age 43. We had never given much thought to what it looked like to really care for a person with a chronic illness. And because of that, because that doesn't fit into our picture of normal, most of us go into those situations pretty poorly prepared when it becomes a reality. Some people call this experience chronic grief, in that it never goes away. And it brings regular reminders that what we had hoped for will not happen. And it impacts even the most well-adjusted families and parents and patients. Missed and delayed milestones are like knocking the scab off of a wound, and it happens on a regular basis. Watching a family member struggle with a chronic illness and lose skills and abilities that they once had produces a grief and a loss in family members that needs to be talked about and is hard to reconcile with that picture. And what these things really do is they begin to work to steal, I think, the most important thing that our families need to keep going, and that is resilience. Resilience is the key to thriving in the world that you find yourself in. It explains a lot about the emotions that we find in families as they are working with and living with their family situation. And this is not only true for dealing with children, but also adults who receive diagnoses. For instance, why is it easy to be in denial early? It's because we haven't missed anything yet. When Haley was 4 and 5 years old and they were telling us things about her cognitive abilities, it wasn't a huge deal because while Haley couldn't read at 5, neither could a lot of her classmates. So she was still in the normal range of her peers, and so that wasn't as hard for us to deal with. It was much easier to say, well, she'll catch up. But when she still wasn't reading or barely reading at 8 and 9 years old, all of a sudden it starts to click in. You know, it's easy to stay in denial when a person receives a diagnosis of cancer, which we have recently with Karen's dad, because he looks healthy. It's easy to say, I can't believe that he's that sick because he looks so good. Well, then the next emotion that we will typically experience is anxiety and fear. And where does that come from? It comes from starting to see signs that we're not sure we can handle and wondering how it's going to happen. And then many people will experience anger. And that's because we see people starting to miss milestones or start to lose skills, and we just don't think it's fair, and that produces anger in some of our families. And then why do parents of kids especially stop participating? Because they've lost hope, because we start to see that no matter what we do, or at least think that no matter what we do, it's not going to really matter, and so why try so hard? I think our greatest work is to help each other celebrate the smallest milestones and to have celebrations when those are reached or when they are maintained, and we need to appreciate every good moment. When it comes to our kids and when it comes to our family members who are struggling with chronic health, we have to be able to enjoy the little things, because that's what will produce the energy that allows us to keep going. Resilience defined as the ability to cope successfully in the face of significant adversity and to learn new skills from that adversity. I'd be willing to bet that most of us on this call have learned more from our failures and our mistakes than we have from our successes. That's just sort of how we are wired as human beings. But if we can look back and see where we've struggled and we've seen that we've developed new skills, then that produces a certain energy in us. The practical definition of resilience is simple. It's the ability to bend but not break and then bounce back. Resilience erodes as rituals and celebrations are missed, delayed, or altered. Haley didn't walk until she was 2. But you better believe that when she finally started walking, it was way more exciting to us than if she'd taken the normal developmental path like our son did. It wasn't that we were happy that our son was walking. It was that it just took a lot more effort when Haley did that. And so the celebration was so much greater. You better believe we put her on the phone with everybody we knew when she finally started talking. If you've ever met Haley, you'd be shocked that she ever struggled with talking, because since she started, she hasn't stopped yet. And there have been times where we wish we could find that mute button. But we're so thankful that she finally did. You know, when my father-in-law over the past Christmas holiday didn't have enough energy to play our traditional domino game, it changed things. And watching him almost visually wither away really steals our joy, and it can really steal our resilience. And it's important for us to just recognize that and to encourage people to find those little things that they can hold on to. And a person who has experienced it carries a great deal of credibility into those conversations. The second thing that I think we really can provide families, and I'll talk faster, is the first one is to say yes, the ability to say yes in the midst of saying no. And I want people to understand that I don't want you to ever feel guilty if that no never goes away. I'll tell you that to this day, while I think I've accepted Haley for who she is, I still wish she was normal. And however you want to define normal. And I believe it's healthy because that wish is for her life to be better. On the pain scale of 1 to 10, it is a rare day that Haley doesn't live and try to function in her life at a 4 or a 5 level. I would give anything for that to not be true. And so I do still say no to that. But while that's a reality, I have to still be able to say yes to all the things that that she needs to live the most complete and full life. If I have any control freaks on the call, this one can be especially difficult, and it can apply to providers as well as family members. We can't get hung up on not being able to fix something. If that's hard for you, understand that especially as a provider, if I am a healthy family member, it's not so much that I need you to fix it, especially if it can't be fixed. I just need to know that someone with expertise in this area is going to take this journey with me. And another family member can give a person in that room great confidence that the person they're with is the right person who's going to go with them on the journey. And when we have those things, I think we create a resilience and an emotional strength in people that allows them to stay on the journey. And that leads me to this question in my mind, and if any of you have some research around this, I'd love to see it. I wonder, what does it cost our system for a caregiver to burn out? How much does it cost us in terms of neglect or poor care or even abuse when the person who's primarily responsible just flat runs out of gas? I believe just having someone available who can provide these 3 things, and that's not all a family member can do, but if they could just give them these 3 things, that at a personal level, that provides a tremendous level of support to the caregiver, not just fighting off burnout, but keeping them emotionally healthy, and that's important. The benefits to providers, the first one is that it reduces the cost of the listening ear. How many times have you gotten caught in one of those conversations that is important and needs to be had, but it really goes outside of your training, or it goes beyond your expertise in a certain non-medical area, and that conversation goes way too long so that the waiting room is filling up? What has that cost you, both monetarily and just in the goodwill of the people who are having to wait. Another benefit of this is that it allows providers to spend more time at the top of their license. My best qualification for this job, yes, I'm a licensed counselor, but my best qualification is that I've got 23 years of experience parenting a child with special needs, an adult with special needs at this point. And so that's my expertise. Let me help you by operating at the top of that license and free you to operate at the top of yours. You know, in our current system, as we move, this can save you time and improve your revenue stream. And as we move, hopefully, forward into a new system that is not so heavily weighted toward pay for performance, we've seen some small studies that show that it will save your network and that it will cut down on ER visits. It will cut down on the length of a stay someone has to have in a hospital. And it can cut down on the number of readmissions that the families we work with actually have. And so there's some real value in this to your practice. I just wonder, what are the things that providers do regularly? And it's kind of tough to ask this question in this format, but that are, number one, time consuming, number two, not a part of your training, and number three, either poorly or not reimbursed at all. And thinking of those things and how many of those things could be handled and dealt with well by a family member, something to give thought to. Then the last that I want to talk about just briefly is the benefit to community support groups. This is really important to us, that people who work with families, one of the challenges we have, regardless if you're a family health information center or a parent-to-parent center in a state, is that we don't have direct access. There's nowhere for us to go. We can't go to the doctor's office and get a list of families that they serve that fit our mission. We can't go to the school and get that list. We can't go to the American Cancer Society and get that list. But as a community support person, being able to work in Dr. Medford's practice, I get almost direct access. Yes, I have to be invited into the room, but we almost always are. And so this allows us to provide families in our community with that mission. One of the big things that led us to look at pediatrics 10 years ago to get involved is because when we first started the Haley Project, we were mostly working through schools, and what we were seeing is that by the time kids got to school, that their parents had already created a way of managing life. In some cases, it was very good and very healthy, and in other cases, it was very unhealthy and out of balance in our opinion. But because it was working for them, they were always very reluctant to change. And so in our minds, we thought if we can get to families sooner, maybe we can invest in them and have input into the way they try to manage this life so that in the end they are healthier. And so that's what we found. One final thing, and I'll leave you with this, and I'll take any questions that you have. It's been 10 years ago that I got to work with a group in Big Pampa, Texas, and for the most part, this group had children who were now adults, and they were beyond the education system. And as they would tell me stories, it would bring tears to my eyes as they talked about being the first group of parents who took their kids with special needs to the local school. And the things that people would tell them and mail them were just ridiculous and amazing in the amount of pain that they had to endure just for their kids to be able to go to their local school. And I never had to experience that because of the work that they did. I love this quote from President Obama's first inaugural address. He said, "Let it be said by our children's children that when we were tested, we refused to let this journey end, that we did not turn back nor did we falter. And with eyes fixed on the horizon and God's grace upon us, we carried forth that great gift of freedom and delivered it safely to future generations. That group of parents in Pampa, Texas did that for the Brad Thompsons of the world. And I want it to be my legacy that I leave it better than I found it. And I'm thankful for people like you who are on this call that are fighting the same battles in different arenas and in different parts of the country, so that when my son's children are engaged in this fight, that they won't be fighting the same battle. Thank you. God bless you for what you're doing, and if you have any questions, I'll be happy to try to tackle them in the last 10 minutes of the call.
Brad, that was excellent in more ways than one, just in terms of talking about your experience, but also I think what's important to acknowledge is that this is a new model of care. So when we're talking about patient-centered medical homes and building the care team, what you've described for a particular population of patients being served by Dr. Medford, you really helped meet the need for that practice and those patients that are part of that practice. I think we can, as you alluded to, that there's a lot of other similar models that are being employed all around the country, whether it's through hiring community health workers that are trained and they're so valuable to the practice because they know the community, they're connected to the people in the community, they've had some of those shared experiences, and I think as we start to look at how we craft these new models in a medical home, we need to think about what are the services that are needed by the population that I'm serving, and then how can we, through certainly as we think about new payment structures, we want to embed this as a role in the practice that really is more of a professional role and is part of the care team. And I think you've certainly spoken to a lot of the ways that we've already started to demonstrate that there's cost savings associated with this and certainly improvements in quality of care. And there's a lot of experiences that other people would probably like to share. But do we have, Lauren, anyone on the phone who would like to raise their hand and ask a question?
We don't yet, but there are a few written questions.
Okay, great. So anyone we got a few minutes left if you want to ask a question live on the phone. Otherwise, I'll go through a few of the questions that have come in. So, Brad, as I started talking a little bit about the payment part of this, how does someone afford to have someone like you in a practice? And if they can figure out how to pay for someone like you, what are some, in addition to some of those benefits, how would they find someone like you in their practice?
That was an interesting question because it's a question that Dr. Rich Antonelli, he actually made it in a statement. He said, if we had a Brad Thompson in our practice, we would do that too. My response to him was, you do. You just haven't been looking through the right lens to find them. And what we have seen in the pilot projects that we've done in Nebraska and are now beginning in Wyoming and Montana is that they are identifying these parents amongst their patient panel. And almost without exception, the people that as we start talking about these qualities, as they start thinking in their minds and making the list, those people are the ones, and they do incredible work in the practices. The way we afford it, I think there are 2 or 3 different ways. If you're looking at a pay-for-performance model, and I know we're trying to move away from that, if I can save Dr. Medford, we found this to be a pretty competitive rate. We pay our partners $15 an hour, and they are part-time employees, so you can adjust the number of hours they work based on the percentage of families or the number of families that you want them to work with. So you can control the amount of salary or wage that you're paying out to these folks. In our Wyoming and Montana practices, they're looking at 1 day a week because they don't have huge patient panels. In Nebraska, they wanted to hire them to be full-time employees, and that works great. What we've done is in these pilots and in these starter samples, we have found grant money to pay for the partners for a year to 18 months with the idea and the open conversation that the practice will look and to see if it's been valuable to them, and if it is, they'll start to assume some of the cost of that person being in their practice. Another way to look at it is that if I save Dr. Medford an hour a week in conversation, and she can bill that hour working with someone else, I've paid for myself, and I've allowed her to operate more at the top of her license. The third way that we can do it, and I recommend this to communities as well, is that in most communities there are small foundations or trusts that are looking and legally required to invest money in different works. And if you have a nonprofit organization that you can work through, you can partner in writing a grant for $15,000, $20,000 that will cover the cost of that. And in many communities where they don't have these huge foundations that are going to build buildings and things like that, this is a great way to markedly improve your community. And so there are people who are willing to invest those foundation or trust dollars into that work. So that answer that question?
Yeah, no, that was great. So yeah, as you mentioned, there's lots of pilots going on around the country, lots of models that are being tested as we're trying to move away from that fee-for-service that you were talking about. We can't just keep doing more and not being as concerned about the quality of the care. And certainly as we're starting to, certainly at the PCPCC and many people who we work with, continue to advocate for more payments around things like care coordination and other aspects of care, following up with people as they're transitioning from one place to another. I mean, a lot of the things that you talked about, are aspects of care that are absolutely critical and vital and being required of practices now, but that don't necessarily, you don't need a license to do. So,
right.
And then having this added experience of walking through and sharing that journey of caring for someone and being able to provide that additional compassionate care that you described, I think can add a lot of real value to the practice as they're trying to build these elements into the care that they're providing.
Right, and we've heard stories, especially from our practices in Nebraska, about learning information that could have saved the system as we look at medical neighborhoods and those kinds of concepts, that a mom was especially intimidated to tell her doctor that her electricity had been turned off while being sent home with a breathing treatment machine that she couldn't operate because she didn't have electricity. And so they were regularly going back to the hospital. Well, when that practice got a partner in there, she didn't feel, she was very comfortable in talking to another mom about her home situation. And once the partner got that information, she was able to make 2 calls to community resources, get the family's electricity turned back on, and the child hasn't been back in the hospital since then. That's a huge savings to your neighborhood.
Exactly. I'm going to ask one last question before we wrap things up, and I know you won't have time to answer it all, so I want to make sure that people know that they can get resources through your website at the Haley Project. There's also a lot of resources that the American Academy of Pediatrics has, but can you talk just a few minutes about some of the training that you've been doing with parents as they move into these new roles? What are some of the elements of the training that's required?
The first element is an emotional awareness training to make sure that they have really accepted, not that they don't have good days and bad days, but that they have really accepted their child as they are and are advocating for the real child and not the dream child. The second thing that we do is really talk a long time about just the practical workings of the office that they're going to work in. We want to be blessings and not roadblocks in the practice. And the first day I was in Dr. Medford's office, I almost got run over 3 or 4 times because it's a busy place, and learning my place and how to fit myself within that flow very important. Important to have a dialogue with somebody in the office about what particular things they really need in that practice for this partner or family partner to provide. We talk about our own emotional awareness. We spend time talking about how to identify where another person might be in their emotional journey. We talk about how to dream new dreams or how to protect people in a particular environment that they might be in. Those are the kinds of things, how to join alongside people in their walk. And then we do the very practical piece of inviting community resource people in to talk about what they have to offer, whether it's a health information center, a parent training and information center, Social Security folks, on and on and on, depending on on the group of people that we're working with, so that our partner knows that I don't have to have all the answers. I just need a list of people that I know I can send them to allow them to practice their area of expertise.
That's great. So we're out of time. I want to thank you so much, Brad, for giving this presentation. And I want to encourage people, you've provided your email address, and I can tell you Brad is very welcoming to any questions that you might have, and certainly you can send them to me as well, and I can forward them on. But if you're interested in kind of exploring this model for your practice or a practice that you're working with, and Brad's done a lot of work on crafting some training around this, I know he would be more than happy to share some of that information with you and to get you linked in with some of the other projects that he's got going on around the country. For those of you who have some experience in something similar like this and you have other resources you'd like to share, we can also get those posted up on the PCPCC website. So I apologize for those who had questions still in the queue and we didn't get to them. We'll do our best job to get those answered for you individually. But again, thank you so much, and we hope that all of you found a lot of value in this presentation. And again, we'll be having several more presentations coming up as we move to this new system that I had described earlier. So again, Happy New Year to all of you, and we look forward with working with all of you in the upcoming year on really engaging patients and families and caregivers in our medical homework. So thanks again, and we will talk with you all soon. Bye-bye now.
Thanks for having me.